Welcome and thank you for joining us today. This is our webinar series called Sight and Sound Bites. It's brought to you by the Eye and Ear Foundation. My name is Craig Smith and I'm a development officer with the foundation. This bi-weekly webinar series highlights research in the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. The research is only possible thanks to generous philanthropic support, so thank you to all who have supported our mission. I want to go over a few housekeeping things for today. For these webinars, we do disable the chat function. However, you can submit questions for the presenter during the Q&A feature. After the presentation, we'll answer these questions for you. We ask that you do refrain from asking any very personal questions that may not be relevant to the broader audience. However, we'll try to answer these questions offline and get back to you through email. And always, you can also send any additional questions to me, and my email with the foundation here is just craig@eyeandear.org. And you should have that in your invitation for today's webinar. We've also enabled captioning for this program, so please feel free to use subtitles as you follow along today. And we'll be recording this webinar and adding it to our website. So if you're not able to view it all, or if you'd like to view it or share it with others, you'll be able to find it on our website next week. Additionally, all of you who will be attending today will be added to our mailing list so you can receive periodic updates on the various research taking place within the two departments through blogs, newsletters, and future webinars. Today's presentation is titled, "Why Do I Sound Old? What Can Be Done About It?" We're very happy to be joined by one of our esteemed faculty members, Dr. Libby Smith. Dr. Smith is a professor in the Department of Otolaryngology and the director of the UPMC Voice Center. And I'll turn it over to her now. Dr. Smith.
Thanks so much for inviting me to be here today. Let me share my screen. All right, so yeah, thank you, Craig, for the introduction. My name is Libby Smith, and I am the director of the UPMC Voice Center here at UPMC Mercy Hospital as part of the Department of Otolaryngology. So I'm going to talk today about hoarseness, dysphonia in our elderly population. So this is really a common mantra that our active seniors here in Pittsburgh and our surrounding areas complain of. So as we lead more vibrant, active lives later on in life, we want our voices to fit with how we feel and how we want to be perceived. So that is our topic for the day. So just so you know, all the patients that are presented in this, they've provided written permission to use their videos. We're going to talk about aging in general. We're then going to talk about how aging affects the voice box or the larynx. We're then going to delve into some treatment options, and then realizing that more than just the voice box is what creates voice. So we're going to talk about those issues, and then creating realistic expectations of what we can do to help folks. Population is aging in general. So Maine, Vermont, West Virginia, Florida are our oldest populations, with about 20% of their population over the age of 65. Pittsburgh, we're kind of like right behind that at about 18%. So, or Pennsylvania is right behind that at 18%. So we are ranked number 8 in the country. This is really due to the baby boomer generation, defined as those folks born after World War II, between 1944 and 1964. And this demographic is really aged between 55 and 75, which is right where dysphonia associated with aging kicks in. So thought that by 2015, the rest of the country is going to catch up to all of us who are already at 18 to 20% of the population being older than the age of 65. So this is becoming really a much more vibrant area of clinical practice and therefore research. Aging as a destination. It's not just a quick process, but we go through this gentle journey of getting there. And there's so many ways to do it, and hopefully we do it really well. This lady has done an amazing job. I'm not sure about smoking off of your 100-year candle, but kudos to her. So people are living longer and staying more active throughout life. Well, that becomes an issue because studies have shown that about 20 to 30% of the elderly population actually seek treatment for a voice disorder. I don't know, a decade or so ago, we were always talking about 40 was the new 30, and then it became 50 was the new 40. And now, frankly, really 70 is the new 60, and I would actually submit the new 50. I'll have 70-year-old patients come in, and you have no idea. Everyone is so active and vibrant that really that chronologic age doesn't really match oftentimes. So with this, not surprisingly, there's been a huge shift in how many people over the age of 65 are still employed, and there's been a 100% increase over the past 40 years. Talk about really what is it that's making us sound older. So the term is called presbyphonia, and that's basically hoarseness due to age-related laryngeal changes as well as pulmonary changes. The changes are gradual. No one wakes up one morning and says, oh my gosh, I became hoarse because today of all days, all of my presbyphonia kicked in. Rather, it's really gradual, really insidious. People don't even know what's happening. But the voice quality is described as raspy, inconsistent, not sure what's going to come out when you start talking. Voice gets really tired. So by the end of the day, the voice gets worse and people can become physically tired as well as their voice just being tired. You'll have decreased projection. Can't throw your voice as far across a room. With that, you'll have more strain because you're trying to power the voice. And so sometimes people complain of pain or just tension in their throat. Sometimes they'll have shortness of breath associated with this, and we're going to talk about how the vocal folds don't always come together quite as well, and that can lead to breathiness. And then also reduced range. Now, I think it's pretty interesting that, when we're all born, no one can tell if anyone's male or female by the sounds they make as a baby. Everyone sounds the same. And then at puberty, we know we split, right? So the males go in lower pitch and the females go in higher pitch. And then what's interesting is that later on in life, we kind of come back together. So the male pitch elevates and the female pitch lowers. When we put all these things together, we really get a gestalt of functional impact, and in this case, specifically how their voice affects their quality of life. It's actually a pretty complex activity. It first starts with airflow from the lungs hitting up against vocal folds, which are actually in a closed position. Those vocal folds then vibrate, and then those sound waves created by that vibration are shaped by everything up above that, which we call our resonating cavity, and our ability to articulate with precision. So that last component we're actually not going to talk about, but just tuck away in the back of your head that resonance and articulation is actually what provides, in most part, our vocal signature, so that I sound different than the next female next to me, right? And two men are next to each other, they sound different. Their vocal folds are probably fairly similar. Male vocal folds are longer and thicker than female vocal folds, but that's what makes males and females have their own vocal signature. Talk about the larynx, because that's like the really cool part. And then we're going to talk about the lungs to follow that. So this is where, if we were in a classroom, I'd ask everyone to, start feeling your neck, because I want you to understand where your voice is generated from. So the vocal folds are housed within a thyroid cartilage, which is highlighted in orange on your screen. That's basically your voice box, the shield that protects the vocal folds. So in males, it's usually pretty easy to find because you have the Adam's apple, and that's the top middle part of the thyroid cartilage. Now in women, our Adam's apple is not super defined and oftentimes not very palpable, and therefore we have a more prominent cricoid cartilage, and that is a little ring of cartilage that the thyroid cartilage sits on top of. So for men, you feel the thyroid notch slash Adam's apple. In that shield, you can actually grab it kind of side to side. Within that's your vocal folds. For women, we feel the cricoid. We go north a little bit, find that shield, and that's where it is. Example of what the vocal folds and the larynx looks like. So I'm going to orient you first, and then I'm going to play the video. So the white structures in the middle of the screen that make a V, those are the vocal folds. So V for vocal folds. Actually, at the very, very bottom of the screen, covered by something that looks like the tongue but isn't. Okay, so the tongue is the lumpy, bumpy stuff at the very bottom. The joints that move the vocal folds are the knobby structures just to the outside of the vocal folds. And then the spine, this always kind of freaks people out, but the spine is at the very top of the screen. So this is an example of what we do in the office to evaluate the vocal folds. So you'll see here, and as it is right now, the vocal folds are open. That allows air passage from the mouth through the vocal folds down into the windpipe or trachea and subsequently down into the lungs. When we make sound, you'll see the vocal folds will close, and you'll just have to believe me that there's air coming up from the lungs, pushing up against those closed vocal folds, and that's what's making that sound, okay? Midway through, you're going to see that there's a change in light in the video, and that is something called stroboscopy, and that allows us to look in more detail to the function and closure of the vocal folds, not just the growth, do they open and close, but you'll see this ripple wave along the edge of them. Then after that, the image is going to get really big. And that's another means of how we look at the vocal folds, again, to take a closer look at vocal fold closure and the edges of the vocal folds. Here you go. Let me know if, Craig, if the audio isn't working. Oh. E. E. Glide from a low E to a high E like this. E. E. Sniff and then say E. 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 E.
E. E. E.
E-he, e-he, e-he.
E-he, e-he, e-he.
Can you sing happy birthday, please?
Happy birthday to you. Happy birthday to you. Happy birthday, Dr. Smith. Happy birthday to you. And many more.
Sing a gentle E.
E.
And a high. And a low. Clear? High E. Low and loud. Gentle glide and hold the high. So I still, to this day, I've been doing this a long time. I still get amazed that that's how we talk. It's so cool. So, okay, if we take those vocal folds, the white structures in the middle that were opening and closing, if we now cut them cross-sectionally and put color on them, this is what it looks like. So that outside purple layer, it's not purple in real life, but that outside purple layer is the outside covering of the vocal fold, basically the skin of the vocal fold. The yellow part is a squishy gelatinous layer, which is actually the most important part to making sound. Followed, sitting on top of this black layer here, which is a ligament, it provides some sturdiness to the vocal fold. And then deep to that is the muscle. So all 5 of these layers need to be really healthy and robust in order to have good voice quality. What happens as we age is that you lose bulk. Sometimes the vocal folds become skinnier. And that's not only in the muscle, which is where we always think of it, but also in that gelatinous yellow outside layer of the vocal fold. But you also tone, and this is where we struggle. And this is thought to be due to neural changes associated with senescence. What happens is the vocal fold doesn't have the same tension, the same tautness, and it just like flops around too much. So I think of it, I give this analogy to patients every day. It's like having a guitar string that isn't tuned up properly, right? So if the string is too loose, you can't make good sound off when you pluck the string. The vocal fold is kind of the same way in the fact that I don't have a way, there is no way to change the tonicity or the floppiness of the vocal fold. All right. So this is basically what happens as our vocal folds gain more years of wisdom. So patients for treatment because they're hoarse, and for a lot of times they just want to make sure that it's not due to cancer, and that's a super reasonable concern. And really searching for that reassurance is their goal for evaluation. Other folks will come in and say, you know what, it's really hard for me to talk. I'm really struggling. I'm so fatigued by the end of the day. And then other people will come in, they say, yeah, I don't really have much effort, and I'm not really worried about cancer. I mean, everyone is, but I'm not like really worried about that. That it's really the quality. I don't want to sound old, right? I don't want to have a raspy voice, and I don't want to have inconsistency to it. I want to know what it's going to sound like so that I can talk with my friends and family. I can like sing to my grandchildren, read them a book, whatever it may be. A couple cases to kind of highlight some of the different things that we can do. So this is a really nice 70-year-old-ish gentleman who developed hoarseness gradually without any precipitating events. It really bothers him both in effort and quality. So I'm going to have you first listen to him. I'll tell you that I have amped up the volume as much as I can, but part of his problem is his voice is really quiet. All right, so that actually is very telling also. And then it's going to roll into his exam.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Okay, and just tell me what brings you in today.
I got a raspy voice, I cough and mucus, and the more I talk, the hoarser I get.
Okay, and how long has this been going on for?
At least 6 months.
Breathe. And again.
In that exam, really, we don't get to see the vocal folds very well. The angle is a little bit off, so one vocal fold looks a lot bigger than the other. That's actually just a function of the angles of the evaluation. But I think really the most telling part of his, other than listening to his voice, is that you can't see anything. He's squeezing so much with all the tissues up above to try to generate what he thinks, what his body thinks is a better way to talk. And so this is called muscle tension dysphonia. And it's really the body's way to compensate for these age-related changes. Options, there's really three. One, assurance, hopefully that we don't think that cancer is the cause of the hoarseness. Voice therapy, to teach this gentleman how to use his skinny and floppy vocal folds better. Or surgery to augment, address the bulk component to his atrophy. So for this gentleman, voice therapy was the treatment that he needed. And this is where treatment becomes really personalized. So our speech language pathologists have a variety of different techniques to, help a patient rehabilitate the mechanics of how they're making their sound. And so he did a combination of what's called flow phonation, resonant voice, and articulatory precision and prosody. Prosody is basically the sing-song, the melody of speech. And so I will let him let you know how it went.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Okay, and tell me, how are you doing since the last time you're here?
I'm doing excellent.
Okay, excellent. And 100% being that you could be 100% better, what percentage would you say the therapy helped you?
100%.
100%.
And a higher pitch E.
E.
And now let's do it with not a lot of effort. E.
E.
Again.
E.
And a lower pitch E.
E.
So his voice is so much better, and it's better because he's using his parts better, right? And so nothing changed with the anatomy, just how he used it. So here's another example. I'm going to let this guy talk for himself.
When the sunlight strikes the raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
And what brings you here today, Russell?
I have a voice problem.
Okay, and the ENT told you had a vocal cord out, is that correct?
Yes, I have
Paralysis.
vocal for both of them.
Okay.
So I love that history. I love how he says, I have a voice problem. So yeah, he was seen by another ENT and said that basically both of his vocal folds weren't moving. So here's his exam, and you'll see it looks much different than the other ones we've seen. There is no sound, but you can see here that his vocal folds, the tippy top of them actually come together, but he's got this huge gaping hole between the vocal folds. He has no bulk, right? I can't even tell you what his tone is because you can drive a truck through there, right? So we think about the issue of how to address treatment. And so really the challenge is the first guy had a software issue. His anatomy wasn't horrible. He just needed a software upgrade. This last gentleman, his vocal fold lack of bulk is the problem. He needs a new computer, okay? And so this gentleman is not a candidate for voice therapy because he doesn't have anything for them to work with, right? And so this is where we work as a surgeon. I work in really close conjunction with our speech language pathologist team here in the clinic. We see people together so they can test what we call stimulability. Are they a good candidate for voice improvement with therapy? And in this guy's case, the answer was obviously no. So this is if we take those three treatment options again, studies have shown that in patients seeking treatment for dysphonia when they're over the age of 65, about 40% just want to make sure it's not cancer. 6% actually go on and have voice therapy, and they do wonderful. About 6% either had voice therapy that didn't help and they went on to surgery, or as in this guy, just went straight to surgery because therapy wasn't going to help. So for the mathematicians out there, I do know that this does not add up to 100%, but that's because people can fall into multiple categories. So from a surgical standpoint, we know that this guy's vocal folds are way too atrophied. They're way too thin. So we have to do something to plump them up. And that's really a talk for another day, but there's a variety of different things that we can do to augment the vocal folds, treat the bulk component of them to improve closure. We always have to have the caveat that we know it doesn't necessarily change the tone of the vocal folds. So this is done in surgery, and I guess I can always come back another day and talk about that. So after vocal fold augmentation, here we go. I'll let him speak for himself again.
When the sunlight strikes raindrops in the air, they act like prisms and form a rainbow. The rainbow is a division of white light into many beautiful colors.
And how have you been since your last visit?
Wonderful.
How do you think your voice is any better, same, different?
Much better.
Percentage-wise, 100% being the best, where do you think you fall at?
What, 80%?
So I will take 80% on his vocal folds any day. So he was obviously super happy. So let's see how they look different so you can put it together.
Good. Go a little bit higher pitch. Good. Do that again, but go longer.
Aren't perfect, but they are so much better. You can no longer drive like a semi truck through them. He's getting better closure, and that equates to better sound. So he can now effectively communicate with those around him. So in my world, that is a home run. If someone just needs bulk, really well. But I'll tell you from experience, there's oftentimes at least a component of tone issues. So, if you feel that someone is sufficiently bulked up, if they say, oh, my voice is 70% of where I think I'd want it to be, that other 30% is probably due to tone. At really what are the goals for evaluation and treatment that patients come in for? If it's a concern for cancer, we're really good at figuring that out. And most often, that's not the issue. In with issues of vocal effort, I'm really getting tired, that type of thing. Oftentimes, increasing bulk or voice therapy are very helpful for that. However, if people's complaint falls more on the voice quality component, this is where we struggle. And this is really where future research is needed to figure out who these folks are and ultimately what's the best treatment for them. Because this is the most frustrating part, both for the patient and the clinician. I promised we would talk a little bit about the lungs now that we've kind of hit the vocal folds. So our other challenge is pulmonary power from the lungs. So what happens to the aging respiratory system? Well, it gets a little bit harder to blow out all those candles. You know that there's changes in chest wall compliance. There's rib stiffening, greater forces required to deform the chest wall. Lung compliance decreases, decreased elastic recoil, decrease in respiratory muscle force. And we know that the muscle strength, both for inspiration and expiration, decreases. And unfortunately, the expiratory muscle strength decreases greater than the inspiratory muscle strength. And this is an issue because when we speak, it's that air on expiration that we're utilizing to power the voice. So what can we do about that? A big part of voice therapy ends up being how to engage the respiratory system to adequately power the voice. Put gas in your car, or nowadays, put electricity in your car so that you've got oomph for your voice. We talk a lot about oomph to patients. So, another really good way to do that is to just be active. Walk, sing, move around, use your voice, right? There is also external things we can do, and this is an example of one. It's an expiratory muscle strengthening device, and it's basically like a little pressure resistance nautilus kind of thing that you breathe through against varying levels of resistance to basically strengthen your expiratory muscle system. I kind of alluded to it, but a big part of people's voices is based on not only the laryngeal component, but also the oomph component. So in the very frail, you can only imagine that this gentleman's voice is going to be very weak. It's not going to be a booming voice, right? Whereas contrary to that, you have someone who's very active, the voice is going to have more oomph, more energy to it. Now, I'm not saying you need to frolic up a hill with your puppy dog, but safest to say you want to remain active. And this is what most people are doing now. And with that increased activity, they expect their voice to kind of hang with that also and be congruent. So it's staying active has so many advantages. I'm going to put in a little bit plug that it also helps the voice. I hope that you now have a better appreciation, I guess, for voice changes that occur as we gain years of wisdom, that presbyophonia is not the same in every person. There's changes in bulk, tone, pulmonary drive, and just general activity levels. And each one of those plays a different percentage for each patient. So one patient may be mostly bulk, another person it's mostly pulmonary, some people it's all of it, right? And that's where the challenge comes on my end and the speech language pathologist end to kind of feather a lot of that out. There are treatment options, and those are all patient driven. So, I mean, I'll have patients come in and I think they sound horrible, frankly, but all they want to make sure is that they don't have cancer. As soon as I do that, that's all that's needed, because they're happy with their voice. They don't have any issues with it. So we are here to give the patients what they need, right? If their goal is so that they can sing in church, so that they can read stories to their grandchildren, that is our job, is to provide them that quality of life improvement. So we have a lot of education and discussion with the patients, because they have to understand why sometimes we can't get you back to sounding as you did when you were 20, right? The parts are different. But if we set reasonable expectations, we're usually really successful, and people in general are very happy. I wanted to thank you very much for taking this journey of presbyophonia with me. I hope you have a better appreciation for voice. I'll do a small plug. It is nowhere near April 16th, but every year on April 16th is World Voice Day. It's actually a day dedicated around the world. It actually was started in Brazil, but every country has their own celebrations for it. We do our own here in Pittsburgh. And so I guess day after tax day, usually a sad day for people. The following day is World Voice Day. So lift your voice, and I'm happy to answer any questions.
Well, thank you so much, Dr. Smith. That was a wonderful presentation. And I think these voice disorders are something that not a lot of people, really think about when they're talking about major medical changes that their body go through as they age. So we already have quite a bit of questions. Please feel free to send in more questions. We have plenty of time to answer them. So we'll kind of dive right in here. So the first question is, once they get to a certain age, should everybody be evaluated by a voice doctor to get a baseline?
I actually don't think so. If your concern is for malignancy, almost always you'll hear something. The vocal folds, usually when cancer is detected on the vocal folds, it's caught really early, because your voice will change, and then that will lead you to see your primary care physician, and then hopefully eventually to an otolaryngologist, so that we can actually look at the vocal folds. If you have anything like ear pain, throat soreness, that type of thing, yeah, that should be evaluated. But just off of hoarseness itself, I don't think it's necessary. I'll have performers though, and cancer survivors who will come in every year, and they will be coming in every year for the rest of their lives as long as I'm here, because it provides them that reassurance that everything's going well. So for some people, that's what they need from that quality of life. I feel comfortable with where I am.
How many people will end up with vocal dysphonia due to aging?
It's about 20-30%.
And
everyone actually sounds different as they age, but only in about 20-30% is that change, I guess, troublesome enough that they seek care.
do long-term allergies affect your voices?
can. If you're really mucusy, like here in Pittsburgh, the pollen in the last month, a couple weeks ago, was just insane. You walk out your car, and it's yellow. That yeah, if you have more mucus, that kind of clogs up the system, and you'll hear like a roughness to your throat, to your voice. But it doesn't have long-term sequelae necessarily. It's more in that moment type of issues.
Many older people have tonsil stones that cause sore throats and can potentially alter their voices. What can be done to help with this?
Elves probably change your voice. Other than you trying to kind of throat clear and stuff like that. Tonsil stones can be removed. That falls outside of my area of expertise, but a general ENT would be a good person to see for that.
Is there a genetic predisposition to these conditions, or are they mostly resulting from overuse of the vocal cords?
That's an awesome question. So there's really no genetic predisposition, and like we don't see necessarily, well, for this topic, you don't see things run in families. It's just a function of gaining years of wisdom. So it actually doesn't have to do with using your voice too much, too little, anything like that. It's just what nature does. And some people, it's a little bit more, I guess, hardwired in their system to be a little bit more than other people. But in general, it's just what happens, and it's no one's fault. It's just part of the process.
So
Now,
here's
there are certain voice disorders that show up as people age, like tremor, that can run in families. They oftentimes don't, but they can.
So here's an interesting question. I think probably a lot of us were thinking as we watched your presentation. How do you get the video of the vocal cords? And is that something that happens in each evaluation? And is it painful for the participant to have the camera?
It's a really great question. So that's part of our standard evaluation. It's well tolerated. We're all really good at doing it because it's what we do all day long. So basically, the first part of those snippets were like that longer first exam was with a scope in the nose. So we put numbing medicine in the nose and decongestant so we can pass this little spaghetti-like scope through the nose. We look down as a bird's eye view onto the voice box and have them do all the vocal tasks. That's the majority of how we do these examinations. And yes, almost always we reassess on subsequent visits to see, okay, how have your mechanics changed from voice therapy? Or, how much bulk do you have after surgery? Those types of things. So we reassess the closure and that wave along the vocal folds. It's called mucosal wave. We reassess that at every visit because that then drives what we need to do next, or if we need to do anything next.
And this might be a hard one to answer because all patients are kind of different, but is there sort of an average length of voice therapy needed to help with dysphonia?
Oh, so that's great. So I think it actually has to do with who your therapists are. So like here we do about 3 or 4 sessions once a week. So it's about a 3 to 4 week kind of program. If you have, but that's because that's all we do. So we're really good at kind of getting to the heart of the problem and kind of more experience on, hey, this is how we rehabilitate this situation. If in the speech therapy world, voice is a very small subcomponent, just as laryngology is a subcomponent of otolaryngology. And so you need to find speech therapists who have that specialized training so that they know what the tricks of the trade are. And if you don't have that, oftentimes people have 10, 12 sessions. That's not uncommon for us to hear. It kind of breaks our heart because it's a lot of time and money. You should really know, especially for atrophy, after like 2 sessions, if it's going to be helpful. And then it's a matter of providing those techniques to the patient, and then you get to practice it at home. And I kind of equate it to mathematics multiplication tables. I remember as a kid going around and like just yelling out numbers and multiplying them because you're always practicing, right? Voice therapy is similar. If you have to practice it, you have to use it every time that you make sound. And the more effort you put into that up front, the easier it becomes kind of your normal way of talking. And it just gets easier to utilize it. But if you're like, oh, I did my therapy session, I'm going to go home and not practice it, it's not going to work, right? So it requires work. But oftentimes people see the progress from it. And if they have pain, they now don't have pain when they're talking. So there's some positive kinesthetic awareness and auditory awareness that people say, wow, this actually works. So I'm going to keep doing it.
Our next question is, are there risk factors for developing dysphonia?
Like in this case, so presbyphonia is just getting older. No, not in that case. I mean, there's other types of voice disorders where there are. In younger populations, we'll see phonotraumatic lesions, where basically improper voice technique, yelling a lot, that type of thing, will cause injury to the vocal folds, and they'll get bumps on their vocal folds that aren't cancer. Interestingly, we very rarely see those in our elderly population. And the thought is because the force of contact is probably less because the vocal folds are thinner and the tension's down a little bit. And so when they do contact, they're not contacting like this, they're contacting like this. So the injury is going to be less. And so we tend to not see those in our elderly folks. We see a lot of vocal fold paralysis due to surgeries and tumors and stuff like that, but for just run-of-the-mill dysphonia, for presbyphonia, there's no risk factors for it.
And we are actually all out of questions, so I'll give you an opportunity to just kind of plug. If we have anybody watching who is experiencing any of these conditions or think that they might be having a vocal disorder, what's the best way to be seen by somebody at the UPMC Voice Center?
Reach out to us is the best way. We have 2 laryngologists, so there's myself and another practitioner, surgeon, as well as a voice specialized physician assistant who is absolutely amazing. And we all do this kind of work. So I don't know if you just give out the phone number. I'm sure everyone's not writing it down right now, but so yeah, just contact us and we can usually get people in a fairly quick, short frame of time.
Well, Dr. Smith, thank you so much for joining us today and giving a wonderful presentation. Again, if anybody has any follow-up questions or would like more information about contacting the Voice Center, please reach out to a member of the EEF team. You can email me at craig@ienear.org. We're wrapping up a little bit early, letting everybody get back to their 4th of July weekend. So we hope everybody has a wonderful holiday weekend. Please look for our next webinar, which will be in 2 weeks, covering ocular trauma. And we'll hope to see you there. Hope everybody has a great day. Thanks.